You.
Very, very good. Very happy to be speaking with you today. We got a lot of good
Great.
topics. You've been a topic of discussion on the forum a lot, and a lot of people have been asking me about your techniques and how are you able to, do these incredible transformations, these Norwood
Hmm.
6, Norwood 7 transformations. So I'm excited to be able to provide them with some of your techniques and your philosophies.
Great.
Um, so, did you want to finish introducing me, or are you
Yeah,
good?
yeah. Yeah, actually, I want to thank you very much to have invited me to join this podcast, and I feel flattered to be alongside with the most brilliant surgeons in hair restoration field of the world. So thank you very much for inviting me, and let's talk about it. Uh, you may start if you want. If we can start talking about my technique. Uh, well, in order to tell everything I do in my surgery, I need to tell how my practice is. So the first thing I do in my surgeries is to make the pre-incisions. We call in Portuguese pre-incisions, that are the pre-made sites
Okay.
where I will insert the follicles after we have extracted them. So the first thing is the pre-made sites. I do everything by myself.
Okay.
And then the second step is, in my opinion, the most important step of the surgery, which is the extraction of the follicles. So why are they the most important step? Because you cannot perform a hair transplantation surgery without those grafts, without healthy and a large amount of grafts are needed in depending on the Norwood class. So this is really the most important step, and I do everything by myself. And guys, we are talking here about FUE. I only perform FUE. And the
No, if you
last, no FUT, yeah. The last step is the implantation, inserting the grafts in the pre-made sites, okay? So the implantations, as I do a really big amount of grafts, I need help from my technicians. So the only thing they do is help me to insert those grafts inside the pre-made sites. Okay, so as I do the pre-made sites by myself, I can tell exactly which are the directions and the angles and the density that we will get after the hair has grown, the final result.
yeah.
So I have pretty much everything in my control all over the surgery by doing this technique. And the technicians, they insert the grafts in the pre-made sites using dull implanters, not sharp implanters. The sharp implanter technique is pretty popular,
Yeah.
known as DHI. You know that the
Yeah.
stands for direct hair implantation.
Yeah.
Yes, and this other technique is called DNI, dual needle implantation. It was a technique described by a Brazilian surgeon, Dr. Mauro Speranzini, and the grafts are only fitting inside the sites that I have already made. So there is no surprise in the outcome. I know everything that will happen if it's done correctly. Okay, so I think this covers pretty much of what I do in my surgeries.
Yeah. So let me ask you about so you do all of the pre-made sites, the technicians help you implant the grafts. Do the technicians wear loops or
Yeah,
any?
of course. Yeah, of
Okay.
course. They must use it, or they won't see the slits, the small slits. I use a very small incision instrument to do the slits,
Mm,
and as I put a lot of density in 1 square centimeter,
yeah.
if they don't use loops, they won't see those small holes. So it's mandatory to use loops. My technicians, all of them use loops, even for loading the grafts in the implanter.
They
I
use.
ask them to use loops. Yeah.
And do you use microscopes to separate the grafts?
In certain occasions, yes, I need the microscope. When I don't have, I haven't harvested enough singles to do the first row or the second and third row of the hairline. Sometimes I need to split the doubles in order to achieve those singles to make the hairline. So in those cases, I use a microscope.
Okay. And how about extractions? Like in your clinic, who does the extractions? Do you do extractions? Do technicians do extractions?
For extraction, you call the harvesting.
Harvesting, yes.
Yeah, I do everything. All the harvesting, I do it. And of course, with a forceps, my main assistant pulls out the grafts.
Yeah.
So it's a secondary role in this extraction. So everything is done by me, and they just pull out the grafts that are loose.
Perfect. Okay. You score the skin, they remove.
Yes.
Separate them.
As I progress throughout the donor area, they go pulling out the grafts.
Okay. Wow. So you do the incisions, you do the harvesting, so you're pretty much involved in every step of the procedure.
Yes, that's it.
And how many surgeries do you do a day?
One surgery a day.
Okay.
Yeah, it's an all day long surgery. Actually, I post every day my cases here on my profile at Instagram, and my followers can every day look what are my strategies and even ask questions here as well.
So on the forum, you know, you've gotten this popularity for transforming Norwood 6s, Norwood 7s, and you've blown up because of the results that you're posting. They look incredible. How do you approach advanced hair loss? Like, do you prefer to do surgeries in sessions? Do you prefer to do mega sessions to try to reach everything? What's your approach when someone's like a Norwood 6 or Norwood 7?
Yeah, for Norwood 6 and 7, actually, Norwood 5, I already start about thinking of doing 2 giga sessions. Okay, if depends on how low the patient wants his hairline, and for Norwood 6, 2 or even 3, and for Norwood 7, 3 or even more giga sessions. So for Norwood 7, I must plan the surgery. I like to place a good density first in the hairline, the front area, and starting at the mid-scalp, finishing at the mid-scalp, and then the mid-scalp until half of the crown area, and then the rest of the crown area, and some refinement if necessary. So the point of restoring a very high Norwood class is whether the patient will have or not enough donor area to do this. So if the patient has a poor donor area in the scalp, you need to look for beards or chest hair, abdominal hair. So if the patient has good beard, yes, maybe it's possible to get a good result. Maybe we need to sometimes to leave a high hairline, but hair transplant is math. It's simple. It's just how many grafts are going to place in the area that you need to cover and what density you need to you can achieve in those cases. Okay, and the most important thing in class 7 and even 6, which has poor donor area, is to try to match the contrast between donor area and bald. Yes, and bald area. So the best thing to do is try to invert this contrast, to put a larger volume of hair on the top and less here on the donor area. But sometimes this is not possible, and in those cases we should just try to match the contrast, to match the density between those regions, and try to get an uniform distribution of grafts all over the scalp.
Have like a homogenized appearance to the scalp, so everything's sort of like equal density.
Yes, that's it. That's it. If the patient has a very good donor area, we don't need to worry about this, and we can just transplant as much as we want. And if the patient still have donor, we can even do a fourth or a fifth session in order to improve the results.
You know, one thing that no one ever talks about, and you know, you're the perfect surgeon to ask this about. A lot of Norwood 6s and Norwood 7s always ask me about the sides, the lateral hump. This, I noticed that a lot of cases I'll see they look good right here, it looks good in the middle, but this for some reason is always like the problem area. Why is that? Why is that such a difficult area for surgeons to restore?
This lateral hump is the last thing that will disappear. So the surgeon may and sometimes they don't worry about restoring it, and the patient may have some amount of hair here, but this hair will thin away in a short time, like 2 years. So indeed, this is really important to plan and try to restore. The way that I do it, I'll try to show this specific case for you. Let me try to put here on the screen so everyone can see. So this is a Norwood 7, okay? So with a very poor donor area. And then I did this lateral hump on both sides, and this is really important to try to restore. And those frontal markings here are for a higher density. Maybe I tried to put here 55 or even 60 grafts per square centimeter. On this right lateral side, maybe 50 or 45, and here the same, so that this hair will grow and come to the other side. This was covered on the first day, and the posterior region, the crown area, in the second day. So here's a spot of the vertex,
the whorl,
and the whorl, and this side getting a little bit more density because it will grow through here. So if you notice this case, this guy had already underwent 2 FUEs, but he didn't get a good result. And he came to me, and I extracted around 1,000.5 grafts from this donor area. Yes, I still managed to get those grafts from here, and the rest of the grafts were taken from beard and chest. So I covered with good density pretty much everything.
Wow. And grafts is that?
Sorry?
How many grafts did you transplant?
It was 9,000 and almost 10,000 grafts.
In one sitting?
Two days of surgery. Yes, 2 days.
5,000 one time, 5,000 the other time.
Yes, especially because I needed to harvest from beard area. I did like that. So asking your answer, this is very important to to build again. And these side humps, they have a different
direction.
How can I say? Yes, direction of the
focals. Go this way.
Yes, it's perfect. Yeah, this goes this way, and the other maybe they turn to the right or left depending on the direction of the natural hair of the patient.
Yeah.
So far, do you have anything to ask about this topic?
I don't know. So I think we should talk about how you planned it, because that is absolutely perfect. Whenever you're a Norwood 6 or Norwood 7, you have to understand that you're never going to have perfect density all over the scalp. So you have to plan it like, where am I going to, almost like a budget, right? Where am I going to spend my money, right? What do I need the most? The most is the hairline, of course. That's #1 priority. But I like how you said the side right there above the hairline is second priority, because that is going to give you a lot of
Yes.
coverage in the middle, especially if you
Yeah.
comb it to the side.
Yes.
That's going to make it look dense, and I think that's a really smart approach to do it, and really focusing the density on that lateral hump there. All of that is so when you grow it out and you comb it to one side, it's going to give that visual density.
Yes, yes. This is perfect what you said.
Yeah.
Actually, I don't like to make this exchange. I like to put good density all over the scalp, but in some situations this is not possible, and the patient must understand this. And one very important thing that we must ask the patient while marking the patient is, where is the direction, the natural direction of his hair grows. If you notice this, in this case, it grows to the left. So I must prioritize the density on the left. This is perfect what you said. It's really what it's needed to do. And another point is the hairline. Unfortunately, the hairline on those high Norwood classes, I cannot lower it too much. I must keep them high, especially in large heads, heads especially. So it's always, they are always a challenge. Norwood 7 are always challenges. There's no easy surgery with Norwood 7. And fortunately, we are getting very good results in those cases.
Yeah. And someone asked me, and your reputation in the U.S. and like on the forum is becoming that of the doctor that does Norwood 6s, Norwood 7s, incredible transformations, and that's really what gives you the wow. But we've also had some people asking about just if minimal hair loss, like if they just want to do the hairline, maybe they have deep recession, but everything else is good. They want to just get a really low hairline, and they asked me, you know, can you share some examples of that, and what kind of density are you able to transplant?
Great question. Naturally, you would expect for a surgeon that managed to cover Norwood 6 and 7 to do this supposed easy case.
Yeah.
But in my opinion, there's no such cases as an easy case or a small case, because this is a Norwood 3, could be considered a Norwood 3. Yeah. But if you look at the markings, I need to cover everything and to advance a lot the hairline, and also to try to increase density on the middle. As I do not prescribe finasteride, I cannot rely on its effects, and thus I need to increase density on these other areas. And also the temporal ridge, the temples, I need to work it as well. So concerning the temples, in this case, with curly hair, the surgeon must be very careful in order not to bring a natural result, unnatural result. So on the temples, I usually put a lower density intentionally so that I can have this smooth effect, this very natural temple. Okay. What about the density of the hairline? I may put the density I want. I think maybe 75 to 80 is the limit. But in those cases, curly hair, thick hair, I can get a very good result with 6 and 6.5 grafts per square centimeter.
Absolutely.
And the temple, you see, I use only singles and very smooth, very not that thick hair on the temples. So this is my approach for this kind of easy case, and we can get this very narrow forehead, very short forehead. I think this should be considered an interesting result, especially on the temples, on the temporal Rich.
Those look excellent. I like that you have experience doing curly hair, because in Brazil is a lot like the US, you know, very diverse. There's Afro hair, there's straight hair, there's fine hair, there's blonde hair, there's dark hair.
Yes, yes.
So a lot of people will ask, like, you know, does Dr. Pittella have experience with Afro hair? Does Dr. Pittella have experience with fine blonde hair? And so,
Yes, yeah.
example, I would say this is a little bit less than Afro, but close to it.
Yeah, this is a sort of curly hair, but it's not
Yeah.
an afro hair. I will show some grafts, but only about the temples. Look here, this region is really soft, really smooth, and we can notice that the temples follow the natural anatomic pattern of the patient. So I must respect those naturalness of the patients in order to design temples, and it should look as natural as possible. Okay, so actually here in Brazil you have a lot of curly hair, and the most challenging thing I would say for curly hair is maybe not the also the extraction, but the point that the density of the donor area
Is less.
yes
Yeah.
it's not a dense
Yeah.
donor area, so the surgeon must be very careful in order not to bring in over harvested areas, and also plan very wisely the surgery in order not to get you know, I need to make a long-term planning to this patient.
Yeah.
Because if I cover only the front area, I would not be able to try to cover other regions afterwards. So this is an example of the grafts I have harvested. Let me just try to...
Curly, those are Afro hair grafts.
Yes, yeah. You can see that they have
Curls, yeah.
not only the curly curvature, but also a sort of splay, internal splay. So also low density in donor area. And on those cases, I need to try to harvest also from beard area, but beard is another challenge. You see here in the
Yeah.
lower part, it's beard shafts. They are really high curvature. So Afro hair, really, they are a challenge, especially in planning and trying to achieve good results. And especially when they have this display, it's sort of 3D internally, like a cauliflower open in several directions.
I see that. The good thing about Afro hair is that it's very similar to beard hair. Usually people that have Afro hair, their beard hair is similar. So it's not like someone who's like very straight hair and their beard is very curly. That, you know, that's difficult to transplant to the top, right? Because it could look weird.
Yes. The beard from the curly hair.
Yeah.
It looks more similar to the scalp hair. So, but it's already very difficult to extract follicles grafts from beard, especially when you have a curly beard. So it's much more difficult to extract.
It's even more difficult. What is, in your opinion, what's the average growth rate for beard hair? Like scalp hair, people say it's 90, 95%. What do you think beard hair is?
Well, actually, I need this topic a lack of scientific trustable studies, because if you do the technique as it should be done, there's no reason why those grafts won't grow. Okay, so if you extract it with quality and then transplant it, it will probably grow. There's no reason why 10 or 20% of the grafts won't grow. So I think it lacks a little bit of you know, comparison studies in order to
To
yeah,
this,
to set this.
what do you think makes you get so much good growth? Because let's face it, every conference, at every conference there is, the main topic is always how do we improve yield, right? That's the most difficult thing, is yield, right? You can get a surgeon who's excellent. He knows exactly how to, create the hairline, how to create zigzags, make everything look natural. But for some reason, they just don't get the growth. Their hair transplants don't look dense. It's just they're lacking growth. So someone like you, the wow factor is that you seem to get incredible growth. Like the growth is very, very high. So what do you feel that helps you get that such good growth rates?
This is a very difficult question to answer because there are a lot of steps during this hair transplantation surgery. To implant one graft, you have a lot of steps. So if some step of this chain is not strong enough, the graft may not grow properly. So that's why I said, when you asked about the beard, if you do everything correctly, there's no reason why the graft won't grow, okay? So, I don't know, maybe because I do everything correctly. And I'm not saying that this or that surgeon doesn't do this, but I have no explanation for this, you know? Maybe it's, I don't know, maybe during the insertion of the grafts, the implanter is not loaded properly.
Mm-hmm. Do you think maybe it's because you're involved in every step and sometimes if you hand it off to a technician, they may not know?
Yeah. This is another thing, is another step of the chain that may not work properly yet. If I'm involved, I'm there and asking my team to, maybe in hair transplant surgery, the most important thing is the teamwork. So it's really important to have everyone looking to the same direction, okay? So if something goes wrong, the chances that the graft will survive are less.
Yeah. People always ask me about technicians and why surgeons don't really share much information about their technicians, but I'm going to ask you, what is the experience of your technicians? Have you trained them personally? Do they come to you already trained? I think that
I started everything by myself. You may already know that there's no formal education in hair transplant field. So I had to learn with my former masters. The first one was Dr. Marcelo Pichon, a brilliant surgeon. And the next one was Dr. Roberto Trivellini. And after that, I started to develop my own way to do this surgery. So it included also handpicking some technicians, good technicians, that they were not trained in hair transplant. And then I started to train them on models. And then when I was, these guys are already ready to transplant with me. We started doing case. So I trained them. So we make not only a team, but almost a family. They are together with me and they're growing with me, and I want them to grow with me as well. So we are sort of family. And maybe this is the reason why things work so nicely with us.
Absolutely. And I see that with every successful clinic. I see that the technicians, the team is like, it's an actual team. And I see that they're successful because they see their jobs as a career and not just like a job, right? Like a lot of these technician run, they're just like there for a job, and maybe they'll leave in a month, and they hire someone else and teach them really quickly. So it's like McDonald's. Nobody really stays for a long time, whereas like a really good clinic, it'll be, you know, they stay there for many, many years, and they know that the clinic is growing and there's going to be room for growth for them as well. So I think that's a big, big, big factor. I did want to ask you, what are your views on punch size? What size punch do you usually use? Do you prefer like a size or?
Yeah. I use 0.95. It's a standard number for me. If I have a very thin hair or a very dense donor area, I usually get a smaller punch like 0.9. And for curly hair, I try 0.95, and then I move to 1.0. It's my maximum for some kind of curly thick hair, because sometimes I really they have the very deep tethering, so I need a big punch to protect from cutting the splayed grafts or with follicles with very great curvature.
I've noticed I've noticed that usually surgeons who use a larger punch tend to get better growth. And that kind of goes back to, I don't know if you remember, but for a long time, FUT, they said that it was superior to FUE because they can dissect the grafts and make them more meaty, have more tissue on them, and they're less fragile, they're more healthier. And then I've noticed that surgeons started trying to go lower and lower. You know, at first 1 millimeter punch, 1.0 was the regular size, was standard. And then, you know, they dropped down to 0.9, and then some 0.8, and then some even 0.7. And I think there's a trade-off between having really low scarring and not enough growth. You know, you want to have a balance of having decent scars, but you want to maximize the growth. And I really think that getting in that 0.9 is the sweet spot.
I agree with that. There is something in the plastic surgery that is especially when we are doing skin grafts. If you have a thick graft, it may not survive as well as a thinner graft. So this concept that the FUT grafts are more healthy because they are more meaty, I think this may be not so good as they thought. Okay, and concerning the size of the punch, the punch I use, I can assure you that it have 0.95 or 0.9 millimeters. There are some punch that they claim to have 0.8 or even 0.7 that indeed does not have this size. Okay, so you have to trust who is producing that punch in order to really know what you are doing in your donor area. So I have an example of a graft that I have extracted with a 0.9 punch. This is a 6-strand graft, and it has a 5 millimeters length. And in this case, I cannot tell that it was my specific ability to extract this graft, but the patient has this kind of high gradient grafts, follicles per graft. So it was possible to extract such grafts. And it would be the same if I had used 0.95 or 1.0. So I think, I don't know, I'm not sure if, larger punches have larger growth, especially because when you have a larger punch, you will probably, when extracting from a dense donor area, you will damage the surrounding follicles. Something called hidden transection. They will transect those follicles internally. So this is happening. I receive plenty of patients who have done surgery in hair transplant mills, and they have a very damaged donor area with no corresponding implanted grafts. So they claim to have 5,000 grafts implanted, but doesn't seem to have that implanted on his head, and the donor is really damaged. So I think this actually happens.
Absolutely it happens. I wanted to ask you about the crown. The crown is something that a lot of surgeons for a very long time never wanted to touch the crown. It seems to be that it's a little bit more difficult. The angles are a little bit more difficult to really get good density. It's very hard to get good density in the crown for many reasons. The fact that you have to lay them almost flat on the scalp is one huge one. The size of the crown is another one. But in your opinion, how many grafts do you think it takes to fully restore, let's say, like a Norwood 6, Norwood 7 crown, even starting from the bottom? How it goes down. If you have an example.
I have an example here. I'll try to show it. Just a second. For instance, this guy, he was maybe a Norwood 5, almost a Norwood 6, and I did first the front area until the median scalp, and secondly I did the crown area. So for the crown, I used it around, it was in this case 4.5 thousand grafts.
Wow.
Because I was just almost touching the donor area, okay? And in order to get this result, and if you want a dense crown, you really need to spend grafts on the crown. And I'm always advancing a little bit on the median scalp. When I finish the front area, I do a gradient to the crown area. And then I come from the crown area doing another gradient to the median scalp in order to get denser, a good density on this region. So this is an example. I'll try to, where's this? Okay. So
he had very fine hair too, very fine blonde.
Yes. Fine blonde hair. So I needed a very huge density here, a very high density here in order to get this crown. And I know this case is have some hard points to solve, like very thin hair, but the skin color matches the hair color. So even if it's not that dense, it wouldn't feel like that. So indeed, crowns are always a challenge. They are always hard to deal with, and you need to spend grafts on crown. You need to spend the grafts on crown.
I want to ask you another question about that case, and it's one of the questions that I'm asked almost every day. I noticed that he had diffuse hair loss, right? He had the Norwood 6 probably pattern, but he had a lot of hair. If you could show again how his before was when you were combing it, you can see that he had hair, but it was very diffuse. He was losing hair at a rapid rate, right?
Yes.
A lot of patients that are in this category, they're really afraid. They're like, a lot of surgeons tell them they can't do it because they may suffer permanent shock loss, and they need to get on finasteride, otherwise they won't do it. But I noticed that you did this, and it's amazing results. And you usually advise, or that I'm aware of, you don't advise your patients to get on finasteride. So this patient got this result, diffuse hair loss without finasteride. How did you approach that? How did you, not damage these very fine follicles?
Yeah, my thoughts on this are, as I cannot rely on the use of finasteride to keep these grafts thick, I need to approach this case as if it were a Norwood 7, okay? So I need to put good density all over the scalp, okay? Again, I will approach it as a Norwood 7, so I need to restore the side humps, I need to restore. Of course, I don't need to spend much grafts here and here. I need to spend plenty of grafts in the design of the hairline and medium scalp. But still, I need to put grafts here and here, okay? Because I cannot rely on finasteride again.
Yeah.
I usually only prescribe minoxidil, and minoxidil can at best keep these shafts alive.
Yeah.
Keep this, prevent these grafts, this hair from thinning away. So I approach as an Norwood 7 and I do transplant plane of grafts in 2 sessions. These were 2 sessions. The first sitting was front mid scalp and the second crown area. And yeah, you were right. The diffuse thinning is very tricky to approach, because if you do not prescribe finasteride or do not transplant to the thinning areas, you won't get a good result.
Yeah, the biggest problem that surgeons have with this diffuse patients is that if they were to do a large number of grafts, right, they damage these hair follicles, the weak ones. The hair follicles are shock loss, and then they don't come back because they were already weak. DHT was already affecting them. So they end up not looking very different. They end up, getting like very diffuse results. And so that's why a lot of these patients are very, very worried, am I a candidate?
Yeah. This is perfect. The patient must understand what you said. So it's very important to come to an appointment where I explain everything, explain this will happen with you. And if they trust the surgeon enough, they will accept this conduct. This kind of patient who has a little bit of hair, still has plenty of hair, he at first won't understand why I'm telling him that he needs 2 surgeries, 2 sessions. So the patient must trust the surgeon in order to get this kind of results. And the result must good look, even if wet. Here's the wet head. And
yeah, it looks good.
Yeah, it must look good even if wet. There's a good density, a good result all over. Even if it's a thin hair, wet thin hair, it should be dense enough to get a good result, a good looking, even if wet.
Let me ask you a hard question, Felipe. I ask you a hard question, and I know a lot of people are gonna like to ask you this question, but it's something that I like to ask all surgeons. What do you do when a patient isn't happy, or if you're not happy with the result? Let's say you did the result, you did the surgery, 12 months later, patient comes back, they said, you know what, Dr. Pittella, I'm not really happy. And you realize, and you even think, you know what, it didn't come out the way I wanted to. We know that no surgeon is perfect. I know a lot of people are watching this and they're like, wow, Dr. Pittella is perfect. But nobody's perfect. So, of course, there's always going to be situations and occasions where your expectations are not met and the patient's expectations are not met. What do you do in those cases?
This is a very good question. When the patient understands what is his role in the treatment, his role is to do the clinical treatment in order to prevent further thinning. And when he understands this and do his role properly, I can sort of assure he will get a good result, because I know the strategy that I'm planning will give him a good result. And if he keeps doing the clinical treatment, minoxidil, or minoxidil especially, he will get a good result for a lifetime. Of course, it depends on the genetics of the patient, obviously.
Yeah.
But if he does everything properly, and we don't get a good result with my planning, you can be sure that I will not be satisfied with the results before the patient realize it. Okay, so I will notice that this is not going to be as I expected, and then I just tell him, oh, maybe we need to do another refinement or transplant a little bit of grafts in those regions. It happens sometimes, maybe because of infection, local infections, or the patient hits the head on the post-operative, and it happens that to lose some follicles, some grafts on that spot. So here's not going to grow as well as I have planned. So come here, let's do a refinement. Let's do something to fix this. So before the patient realize this, I call. I realize. Yes, I have already noticed that, and I try to. I want to give a result to the patient. Okay, so if it doesn't happen, I call him and let's do something to fix it. Okay,
that's very good. I always respect the surgeon that stands by their work. You know, it's very important, and I think it's very important as a patient to understand and realize that what your role is, right? Following clinical protocols, following the instructions, post-op instructions, but also I think it's also very important for them to understand, like, manage their expectations. And that's a perfect segue of how do you manage someone's expectations. Let's say a guy who is a Norwood 7 comes in and he says, you know what, I want hair like Neymar. I want to. He's like Norwood 7, and he's like, you know, showing you a picture of Neymar. I want to have hair just like him. Do it for me. How do you explain to them? Look, these are the realities. This is what I can do, and all of that.
So the first thing I ask for the patient when he comes to the appointment is, what are your expectations with your hair restoration surgery? And if he says something like you're saying, I want Brad Pitt or Neymar hairline, I cannot, you know, say to him that I will do this, because probably it will not be possible. So when marking the hairline, the first thing that I must keep on my mind is that I need to bring a natural result to the patient. So if his face, his anatomical parameters are not compatible with a short forehead, I cannot provide this to him. So I say to him, no, this is not possible, but I explain why it's not possible. So to mark the hairline, I need to take into account the insertion of the frontalis muscle, which is the muscle that rises the eyebrow. So I ask him, rise your eyebrow, let's see the rim of the frontalis muscle. This is where I can place the limit for me to place the hairline. Okay, so I cannot go below this limit, because we start to maybe get a natural result, a strange result. So I must respect these anatomical limits. In hair restoration field, my objective is not to create anything, create a hairline, create a strange pattern of hair. My objective is to mimic nature, to try to bring to that patient the most natural result I can give to him. That is why, in other words, I'm strongly against templates and stencils in order to mark the hairline. So I think a hairline is something as a fingerprint.
Exactly. I was just about to say that. I was thinking that in my head.
Each patient has his hairline.
Yeah.
And that the hairline that fits perfectly his face. Maybe the frontalis muscle is a little bit longer than Brad Pitt's or
Yeah.
Neymar's. So I cannot provide this to the patient.
Yeah.
It's his nature, okay?
And what about when they say like, I want to have so much hair that even if I'm under light, you shouldn't see my scalp, or if I'm go swimming and it's wet, you shouldn't see my scalp at all. We know that the reality, like the guy you just showed me, right? His hair looks good wet, but it's not looking like it's never going to look like when he was a child, right? That's just never going to happen because you can't multiply hair. You're not creating new hair. You're just rearranging his trying to make it look more thicker. So how do you explain that to patients when they have these high expectations?
Well, when the patient has a very poor donor area, I shows him the donor area and say, look at this donor area. This is the best thing I can do to cover your head. So yeah. This donor, you still can see the scalp, the skin of your head, even in the best of your density, which is this donor area density. So I cannot create anything, multiply grafts. So the best I can do is something similar to this all over your head. So this is some way to try to convince patient that this may not be possible. Let me show you this case. He was a Norwood.
This is the case I wanted to see. So this was a Norwood 7, slick bald. What would you categorize his donor area?
A very good donor area. I was lucky in this case because he had a very good donor area, and I've done around 10,000 grafts in this case. And the first, I've done the front area and then the...
Now 10,000 with beard or 10,000 all scalp?
I had to harvest a little bit of beard as well. Okay, so it looks really natural, but if you look here on the crown area, you still get the
little bit of skin.
Yeah, a little bit of skin. Okay, but it's pretty good, homogeneous, distributed all the grafts, and even when it's wet, yes, we get this good looking. And of course, as far as the patient still have donor area, we can try to improve it a little better. So in this particular case, what would I do? Maybe to restore a little bit of tempo, maybe bringing down
the
hairline a little bit and improving also the density in the crown area. But this is a result that changed the patient's life. Yeah.
Wow. I mean, that's incredible. 10,000 grafts. How many grafts did you use beard? Was it like 2,000?
In this case, around 1.5 to 2,000 grafts only, not a large amount of grafts, because he had a very good donor area. And if you look, you still can see pretty much of donor here.
How many grafts would you guess he still has? If you wanted to.
Yeah, maybe I can extract here 2,000 grafts without worrying about the aesthetics of the donor. Maybe
that's
2,000 grafts.
Put him up to 10,000 FUE grafts.
Yes.
Wow. That's very, 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 very few surgeons are doing this. I mean, I could literally count them on one hand, all of the surgeons who are doing these type of numbers, which is with FUE, which is incredible. I think that your approach was fantastic, but I also like that, you showed some of the things I was talking about, right? Like his crown, it's very good, but it's never going to be perfect. And sometimes these, Norwood 6s have to understand, look, you're always going to see a little bit of scalp,
Yes.
I'm sure he can come back, and if he was really bothering him, do another 1,000, and it would probably look really good. But the fact is, you're never going to look perfect. you have to kind of accept some of the limitations with surgery, but you are really, really getting close to those, to creating really fantastic work. I'm really, you know, dumbfounded. It's crazy.
Thank you.
Another thing I wanted to bring up when you were talking about patients with low donor, I've noticed a lot of patients will say, you know, I want to, maybe they have low donor naturally, but they have a little bit of hair loss, and they'll say, you know what, I want to do 80 grafts per square centimeter in my hairline. And you look at even the best in their donor, and they have 65. So, like you said, you can't go against nature. You can't do more and like more than what your donor has. You know.
Yeah, this is a very dangerous approach if I accept to do this.
Yeah.
Because other regions may thin away in 5 years, maybe 10 years. And he will get a very thick hairline with everything empty behind his hairline. So this is catastrophic. This is not good. No.
Absolutely.
So the patient must understand this kind of results. And even if you say, oh, I'm taking dutasteride and finasteride and doing mesotherapy, PRP, all my life, but even so, he may get a shock loss by COVID or I don't know.
Yeah.
And his hair will thin away and he will get very strange looking front line.
Absolutely. One last question, Dr. Pittella, that I wanted to ask you, and it's something that everybody on the forum is always asking. Why is it that you don't prescribe finasteride? You're one of the few doctors that doesn't prescribe finasteride. Well, two questions. It's going to be two-part questions. One, why don't you prescribe finasteride? And then two, what are your thoughts on topical finasteride? Will you maybe one day prescribe that?
Well, the point I know, just a quick disclaimer before I bring my opinion. I'm not telling that the surgeons who prescribe finasteride are right or wrong. I'm just giving my medical opinion here, okay? Mm-hmm. So, finasteride has, or dutasteride has really few percentage of side effects regarding